Hello, everyone. Hello.
Hi there, Eunice. Yeah, we can hear you.
Oh, hi. Yeah, hi. I think we can start. We are about a minute behind, isn't it? Yeah. Welcome everyone to the to this session, which will particularly look at the Zambia antimicrobial stewardship activities that has been taking place. I don't have a lot to say other than introduce this session to everyone. And I can see there are about 21 of us who are here. I just want to check whether we have a representative from the Ministry of Health who is supposed to give a keynote speech for this session. I think as of yesterday, we had agreed he was going to be here, and that is Mr. Mlenga, the Deputy Director of the Pharmacy in Zambia. Is he around?
I can't see that name in the participants.
I don't know whether we can't obviously wait for him because we don't know when he's going to come, but maybe we can still go ahead and do the presentation. I don't know what you think, Richard.
Yeah, I mean.
So can I just check what you said his name was?
Mr. Mlenga.
Okay, just checking that he was not in the waiting room. Thank you.
Let's see. To me also get the correct name.
There's an Emmanuel Mayenga. I don't know if that's that person's in the main room. Is that who you're referring to, Eunice?
Yes, that should be the one.
Assigned him to our room now, to the room now.
Yeah. I also just want to check his number because sometimes he could be struggling. I can call him.
I think we have Mr. Mayenga in the room now.
Good morning, Mr. Mlenga. Good morning. I'm not getting any response here. Should we go ahead then if he's not responding?
Yeah, I mean, it's a shame that if he won't be able to hear the partnership. Have you got his mobile at all, Eunice, or is there another way you can contact him? Because it might be that
I do.
Maybe
I do have.
If you could send him a quick message, and then we'll get cracking. But hopefully he'll be able to join a bit later.
Yes, I do have his mobile. He's Mr. Matthews Mwale. Let me just give me a minute or so. Let me try contacting him.
Yeah, thank you.
I'm not getting any response from his mobile number. So perhaps I suggest we just go ahead. And if he joins, then we'll call him at some point to give us his opening remarks. It's a shame because they are up to...
Sorry, he's posted in the chat that he's joined now.
Oh, Mr. Matthews Mwale?
No, so that was Emmanuel who's just posted.
No, his name is Matthews Mwale. So I've checked on the list. There is Mr. Emmanuel Mayenga. He's not the one. I'm looking for Mr. Matthews Mwale.
Okay, yeah, I don't think he's on the call either in the main session.
So Mr. Mwale I don't think he will join at the moment. He's in another meeting for the COVID response. So I think he has a clash of the meetings. Maybe that's why he's not even picking his call. Thank you.
Oh, thank you so much for that. Anyway, in that case, then we can just go ahead. We are already behind as it is. And we can just go ahead with the presentation. May I ask from the partners, among the partners, for someone to take notes and then give feedback during the plenary session today at the end of the day? Any takers from the partners in Zambia?
Just to say, these are really headline notes.
Guidance.
So it's when we go back into plenary, there'll be kind of 2 to 3 minutes of feedback. So we're really just looking at headline, achievements, challenge, and recommendation to the ministry. And there's a link in the chat box to a form that you could use, which has the headings. And we're just looking at 1 point for each category. So yeah, if there's anyone from the Zambia Health Partnership who would like to just detail that while we're talking, that would be really great.
Is there anyone who is going to volunteer on that? We need to have someone quickly because we are running out of time. As you are thinking of someone, I'll have 15 minutes to present, and then at the end we are going to have 5 minutes of questions. So if we can have someone who can take notes and then someone to present, I think we should just go ahead. Richard, what do you think?
Just to say, I'm happy to take notes. Sorry, Diane here from CP. Happy to type the notes, but it will be really great if a member of the group can be the one who feeds back. So I can do the typing of the notes, and if anyone's willing to also add their own notes in as they hear them, the link is available there. But it's just really someone to verbally put back that final comments. Thank you.
Thank you so much, Anya. So someone from the partners who present, Anya will take the notes. So I think without any further ado, can we go ahead with the presentation, please? You have 15 minutes. Who is presenting?
Hello, can you hear me? Hello?
Yes, we can.
Okay, great, thank you. I was hoping David was here in the house. Is David here? Just checking.
Yes, I'm here, Aubrey.
Okay, David, are you able to take it up?
Yeah, I can take it up. Somebody will share the screen for me.
Yes, please.
Okay.
Then I can just also help out Diane with the note taking then. Thank you.
Okay.
Over
you
to you.
Also help to present the notes?
Yes, please. We can co-present as David will lead us. I can be jumping in the presentation as well. Thank you.
Thank you. So David, go ahead. You have 15 minutes.
Okay. Good morning, everyone. Greetings from Zambia. Yeah, so I'm presenting the Brighton Lusaka Health Ring, the health system strengthening, which was supported by 30 framing hoppers, Commonwealth pharmacists, Ministry of Health, University Teaching Hospital, University of Zambia, and many others. Next. So the slide there is showing us some of the achievements that we did as a link. We had our grant from framing through 30. Our target was mostly involving the pharmacists in antimicrobial stewardship programs. From this project, we were able to develop an AMS team that was established at UTH. And also we combined it with IPC, that is infection prevention and control activities at UTH. Through our project, we're able to lobby for the recognition of a pharmacist who shall be a specialist in AMS, that is antimicrobial stewardship, so far has been appointed. We also did global PPS for University Teaching Hospital. We did a pilot and we did another second one in the beginning of the project. After the pilot project, the global PPS, we identified that we need to work on the drug chart because University Teaching Hospital is using one standard chart which covers for all the drugs. But we learned from the partnership from our colleague from Brighton that we need to have a dedicated chart for antimicrobials. So therefore, we modified the chart and we were able to fill that chart and we tried to pilot it. However, could not continue piloting it because of the COVID came in and the burden was so much, and there was also restrictions in accessing a University Teaching Hospital. We are able to also approach the UTH antimicrobial guidelines. We did also the audit, and we also did the behavioral change to adopt a new drug chart. This work is still ongoing, and the discussion is still ongoing because that chart has been appreciated and is so much focused to antibiotics, where we have date to review, number of days to take, time to change. Those reminders are always there. Some of the pictures there where we had our initial workshop, in AMS workshop, where we discussed with stakeholders from Ministry of Health. We also discussed from other hospitals like Ndora, also came in. We are also able to develop an AMS modular training program, which was gotten approval from Health Professions Council of Zambia, which is hosted with the University of Zambia. This is supposed to be short training course for practitioners in antimicrobial stewardship, where they will be able to establish antimicrobial stewardship program, to be able to implement and establish the committees in infection prevention and antimicrobial committees. We also promoted the BEAR-DRAW, the Apple dress code, which has been adopted by the Professional Association, the Hospital Pharmacists Association. We also expanded the hand rub production of WHO hand rub production because we also realized that infection prevention is very critical. It became so handy at this time with COVID, where the guarantee of getting quality hand rub was also a challenge. So we expanded the hand rub making using the WHO formula to 5 teaching hospitals across the country.
David, sorry, just to come in there. So it's a little bit hard to hear you. I wonder if you could speak very clearly straight into the microphone. That might help. Thank you.
Oh, okay. So I was saying we were able to develop an AMS model training program, which has targeted at health practitioners, ranging from medical, pharmacy, nurses, and all of those who are involved in use of antimicrobials. We also promoted the bare below the airport dress code, which was adopted by professional association, the Hospital Pharmacists Association. We also expanded hand wrap production to 5 tertiary institutions, which we realized that quality hand wrap, especially in this time of COVID, was very critical. So we trained pharmacists in these 5 hospitals to produce their own hand wrap because it was becoming so much costly for the hospital to buy already finished. And also quality was not guaranteed. So we made sure that our own pharmacists are able to make this hand wrap using the WHO formula. We also trained and oriented many health workers, more than 120, in infection prevention, especially at this time of COVID, because it's one of the requirements to stop COVID transmission. Infection prevention is very critical. Yeah, we also, the slide is a bit small. We also managed to share experiences with our UK team and Zambian team, and we learned a lot from each other. Can go next. Can go next slide. However, despite those achievements that we had some challenges. I think some of the challenges is the hierarchy structure in the midst of our health system. We cannot go to any health facility within Zambia without passing through the permanent secretary or the head of the Ministry of Health in Zambia. Sometimes we used to take long, more especially with COVID, that the permanent secretary was also contributing with other important tasks to combat COVID. Administrative burden of the project, the administrative part of it, was our first time for most of us. We are health workers that were able to complete this. So I think that was another thing that we had a challenge with. COVID is a both-way thing. It was a challenge because we couldn't conduct our final PPS because of restrictions.
Hi, David.
Yes.
David, you keep moving away from the microphone. People can't hear.
Oh, is it? Yeah, so I was saying the challenges was the hierarchy in accessing the health facilities in Zambia, where we had to go through the PS all the time to implement our activities. And also, we said also have a challenge on the administration of the project itself, as all of us, most of us were health workers and have little or no accounting knowledge and other knowledge which are required. The other challenge was COVID, though it was also an opportunity for the pharmacists in Zambia to showcase their proficient training of making hand wraps. So COVID was both a challenge because we couldn't do our final global PPS. We couldn't continue training in these facilities or renting our staff on the IPC. However, it became an opportunity also to showcase our practice. Next slide. Future plans as a link, we're looking forward to implement a hand wrap and spoke model for IPC training and hand wrap production. We have seen this in the previous 5 tertiary institutions to be working well, where the facility are able to produce their own hand wrap. So we would wish to go forward and make other hospitals within Zambia or other 6 districts to be added to be producing their own hand lab. We also wish to advance the practice of fellowship for pharmacists in clinical pharmacy. We are focused also much on the communicable diseases, but also there's also another challenge coming on non-communicable diseases like hypertension and diabetes. So we want to work this with CPA, AMS fellowship, and see how well we can advance the practice of pharmacists in Zambia. I think that should be the last slide. Thank you very much for your attention. On behalf of all those who have been listed there, Aubrey, Fiona, Samantha, David, Luke, Jasmine, Anja, Uchizi, so many to mention. We are very grateful. Thank you, team.
Thank you very much, David. I now open the floor for just 5 minutes or even 3. Are there any questions from those who have been listening?
I have one, Eunice, if that's all right.
Yes, please go ahead, Richard.
Yeah, hi, this is Richard from SET. Thanks, David, so much for that really illuminating presentation. I was interested by the challenges. I think we're always slightly more curious about those. But I think, did you say that one of the challenges was you had to go through the permanent secretary kind of every time that you needed to, was it conduct a new activity or do something within the project? I wondered if you could, if that was right, and whether you could just speak a bit more to that and kind of how much how many hoops did you have to jump through and how often was that?
On the permanent secretary or accessing the facilities, I think it's within our standards here that we cannot access any facility unless you inform the permanent secretary. Because when you go to that facility, you need that data from the PS. If you don't have that, you can't attend to it. Within the same project, every time we needed to visit the facility, we have to pass through the permanent secretary, even using the same project. So I think that was a bit cumbersome. We thought maybe if the director of the hospital was able to give that leeway to accept this, that it would be much easier. However, for here, we have to go to the PS all the time.
Yeah, okay, thanks, David. Yeah, it'd be interesting to see how we can all work to make that a bit more efficient. But yeah, thank you.
I have a question as well. So just an apologies if I've missed this. So was the need to get the letter to access a facility because members of the projects were not within the facility? So I'm trying to ask the question, if the chief pharmacist is part of the project within a hospital and they want to do something in their hospital, do they still have to go to the permanent secretary first?
Please introduce yourself briefly.
Oh, sorry, I'm Diane. I'm CPA, one of the program lead from CPA.
Thank you, Diana. Yes, Diana. Yes, despite the chief pharmacist being part of the facility itself, we have to get that permission from the permanent secretary.
And sorry, apologies for teasing this out. I'm going to put my video on briefly. Apologies for teasing this out a bit because I think this is really important for future and understanding. So, in terms of so do you submit what is the project plan submitted in advance? And then every time you have a new initiative, say you wanted to train the health workers in something, you have to go back to the Ministry of Health, or is it because you're going to new facilities? I'm just trying to understand, because I think this is really critical for future projects.
Yeah. So what we're saying is,
I think Diana,
yes. Eunice, you can come in.
Yeah, so then I think the process in Zambia is that whatever you want to do, whether it's contacting a nurse on an official capacity, whatever thing you want to do in any health facility, be it at community level or at national level, you have to go through the Ministry of Health. They have to endorse, they have to give you permission to go through there. Otherwise, if you go there without any endorsement from MOH, no one you. So those are some of the red tapes that we have to cross as we do our activities, health activities in Zambia. And it applies, I think, if I'm not wrong, to all line ministries, even the education ministry. If you have to contact a school on an official capacity, you have to go through the Ministry of Education headquarters and others. And these things sometimes take a long time. Sometimes and it has to be in written. You cannot send an email, or you cannot just phone or just go in person. It has to be in written so that the PS reads through and passes it on to the relevant individuals before you are getting that permission to go ahead and do what you do. So it's that kind of challenge which David is talking about.
And can that be done in advance? So for example, because I'm saying this so that at a programmatic level, we can see what support may be available. Can it be done in advance so that we help provide that case, and then obviously is it that you need evidence and things like that to show why the program is useful?
Yes, it has to be done in advance. Obviously, it depends on how fast you want to do that program. Normally, really, I would give it a week or even 2 weeks because these people, like the permanent secretary, is really busy. Sometimes he may not be at his desk. So it to sit there until the permanent secretary does it. So you have to do it in advance. And sometimes, for example, for THET, which has got a country program, we can do it ourselves from THET Zambia. But if it's a program which is headquartered, for example, in UK, the letter must come from the UK.
Yes, Diana, in addition to that, for example, at the inception of the project, you agree with the peers, then later on you want one of the members of staff from that particular facility. They're not going to move, not until you write to the peers that from that program that we agreed, now we want this person to come and be trained in this. That's how cumbersome it is.
Sometimes they have to choose their own person. You might decide, I want Eunice to be on this program. Then they might think otherwise to say, okay, Eunice is not the most appropriate person on this program. We want to put Diana on. So half of the time, really, it's not up to you sometimes to make that decision.
Diane, could I just add, this is Sarah Marshall, so I'm on the Brighton Lusaka Health Link. Anya, who is our UK lead, can't join with audio, so she's been putting some discussions on the chat. And she was she's just commented that they also wanted to raise the recognition, the awareness of the project within the Ministry of Health. And she commented on how the Zambian members have been amazing in navigating the system and have enabled the project in usually a timely manner. But Anya's point is that I think that the UK High Commission could be very useful in opening these avenues. Just to pass those on.
Thank you.
Yeah, that's very helpful. And yeah, we have a relationship with some high commissions better than in other countries. And so, yeah, that's definitely something we can look to.
Okay, David, go ahead. Anyone with another question?
Mine was an addition. Aubrey here. Okay.
Go ahead, Dr. Karugia.
Okay, thank you. Mine was an addition. So what David was pointing to and what also you've clarified. So initially when our project started, just to clarify the context, was that it was housed at one facility, that was the university hospital. That's where the initial permission to do the project was. But as the project evolved and the activities started rolling out, there were certain aspects of the project that needed to be, wanted to expand to the other facilities. So that is where the aspect of the permission and the MOH requests had to go in. So you can imagine that kind of scenario where the project is housed at one facility, then you need to do other activities with other facilities, then you need to get those permissions in and to request for particular personnel to be part of that activity. So that's where the red tape aspect was mostly affecting our project.
Thank you, that helps, because that's what I was trying to, I think that's what I was trying to get at, because I understood that you had permission, but if you want to go into new facilities, then you'd have to go back and get permissions again. So I guess that's helpful in maybe having templates that can be used to make things a little bit easier. Thank you.
Thanks.
Are there any further questions?
I've got a couple of questions from the typing of the notes part, please. And I've just put something for you in the chat, please, Eunice.
Shall we then close this session, and we have another session which should have started 2 minutes ago?
I'm sorry, Eunice, we can't close yet. Just sorry, I'm so sorry. We just wanted to ask recommendation. What one recommendation would we want for the Ministry of Health, and if there is any way we feel the project has contributed to the NAP directly? So
we still have 15 minutes if we want.
Oh, sorry. Oh, yeah. Apologies. Ignore me.
Okay, maybe I can take a bit of that. Is that okay, Eunice and Diane?
Yeah, sure.
Excellent, thank you. So yeah, so what David has presented to us mostly is about what we've achieved, and I think also some of the challenges. So in the plans, I think the plans, we kind of identified that IPC, or infection prevention and control, is one of the areas where we can strengthen, and there's an opportunity to do that, especially currently with the COVID situation and all that, which requires a lot of collaborated effort within not just the partnership, but everyone else. So we thought that strengthening IPC capacity, not just in the trainings and all that, but also in the capacity for players such as pharmacists to contribute, because our project initially was targeted at championing pharmacists' role in AMS. And one of the roles that I think we've identified is that the pharmacists can actually help in IPC, not just for the in-house production of alcohol-based hand rub, which is one of the mainstay of prevention, but it also helping to capacity build other health workers to be able to appreciate the role that IPC plays in not just COVID prevention, but generally prevention of all other infectious hospital-acquired infections. So the hub and spoke model that David talked about in the last slide was one of the areas we're trying to recommend, that perhaps not just a project, but a program in this regard can be championed by the Ministry of Health, because we know we have institutions that are stronger in IPC, which can serve as hubs. And then we have those other remote facilities which do not have the capacity yet, which can become capacity built. So those hubs start to feed into capacity building the other facilities. We're not using any resource from outside, but we're using our own resource, which we've capacity built already, like at UTH, at Ndola Central Hospital. These are very strong institutions in terms of IPC, hand rub production, and all these other activities that we talked about. So them playing a role to become champions and capacity building the others. So like a snowballing effect where you strengthen from one strong end. So I don't know if that recommendation can be passed on, but I think that is one area I wanted to push forward. There's opportunity to do that, I think, with what we've already done in the project that we did. Thank you. Over to you.
That was a call from Mr. Mwari, who should have represented the MOH. He's locked up in a meeting, unfortunately, so he won't be with us. Okay, are there any further questions? We still have a bit of time, I'm told. Or am I mute?
Can I add one more comment?
Yes, please.
Okay, thank you. Yeah, so in terms of contribution to the NAP, the National Action Plan on Antimicrobial Resistance, so Zambia, yes, has also bought into, if you read our National Action Plan, has bought into the five or six main global areas for strengthening antimicrobial resistance capacity. One of them is IPC, and I think that is where we're trying as much as possible in these projects to bring to light and strengthen. So in terms of contribution to the National Action Plan, we've tried to identify IPC as an area where we can strengthen as a country. It's one of the key areas of the National Action Plan. The second one, I think, is to do with capacity building, increasing knowledge and awareness about antimicrobial resistance. And I think in our presentation, we highlighted that aspect, that we did focus on also developing tools that can be useful for capacity building to increase knowledge among health workers. So we came up with a training package, an AMS modular training package for health workers, which I think we're trying to see if it can be mainstreamed by the Ministry of Health, perhaps buy into the concept or indeed adopt it as a national standard and see whether it can be used to train health workers. We know it's difficult to do contact-based training now, but we can leverage even using online platforms and other platforms to deliver this knowledge. So we thought that is a good contribution to the National Action Plan, including IPC training and other behavioral aspects like the bear below the elbow practice. All those things need to go into the package to be able to be used as an aspect that can strengthen AMS and AMR knowledge and capacity among health workers. So we thought that would be a good contribution. And I think to just recommend that perhaps those can be taken forward by the appropriate authorities to see that they are able to be actualized. Thank you. Over to you.
Thank you, Dr. Karungia. We've had Orida hand up. Orida, do you have a question you need to ask? Hello, is Orida here? Hello? Okay.
I can no longer see. I think they must have dropped out the call.
Yeah, we seem to have lost Orida. Is there another question? I've got one. I've got one question that I just want a bit of clarification, I think. And this question is in respect to how the partners worked together in country, both in the UK and here in Zambia, to scale up this. Because obviously this, to me, it's quite a success despite all the challenges. So how did you do it?
Yeah, so I think we used a lot of Zoom meetings and emails. And I think in most of the times we're able to come to a common understanding, common goal, and implement the work. So we used a lot of the Zoom almost every week for the Zoom meetings and extending emails to guide one another and reporting what was happening down here and getting guidance from the UK team. So for me, I think the partnership really worked well for me. It really worked well for us, and I think we learned a lot from each other.
Yeah, I think in addition, Aubrey again. Can I speak?
Yes, Aubrey, you can add.
Oh, yes, you go ahead. Sorry, I was muted.
Great. Sorry for talking too much. I was the country lead for the partnership in Zambia, and then Anya, the country lead on the other side in the UK. So from our side, I think this partnership did not start with this project. So we've built a long relationship really within the partners that are in the Brighton Lusaka Health Link as way back as 16, that's I think the time we started working together on other activities, of course, and then the project came in about 2019. So you can see that we've established a long-lasting relationship, not just professional relationship, but also I think at personal level, we have developed trust in each other as a partnership to do our works together, even across the distance. So we've been able to collaborate well using like David said, the online platforms. We do have regular meetings as a partnership where we just update each other on activities, not just of this project, but anything else. We've collaborated on publications and also attending conferences. We've done cross-country sharing through visits. So the UK team has been to Zambia, the Zambian team has been to the UK in Brighton, to be able to exchange learning and to learn about each other more. So I think the main point is that the partnership has worked well because of this long developed trust and working together even before the project. So other subsequent projects also are able to succeed because of that built-in trust that this partnership has. Thank you. Over to you.
Thank you, Dr. Karungia. Do we have Dr. Eva here? Your hand has been up.
Hi, Chair.
Yes, I'm here. Good afternoon, everybody. Can you hear me, guys?
I can hear you.
I just have a short question. Okay, I have a short question on the AMS modular training program that they have developed in Zambia. So how long is that program, and was it done virtually or was it face-to-face?
Yeah, okay. Can I respond to that quickly?
Yes, please.
Yes, thank you for that question. Yes, so we kind of have it as a working plan. It hasn't run yet. So we were developing this AMS training module as a CPD program for health workers in Zambia. So currently the modules are done. So we've packaged them into a deliverable. And then we now in the process of doing the accreditation of the CPD with the regulatory authorities in Zambia, the Health Professions Council, to be able to house it perhaps at a training institution where it can run as a CPD program, and then health workers can undertake that and be able to be certified. So the process is still ongoing. We haven't yet finalized its rollout. And I think the other part is the engagement with the Ministry of Health, to be able to see whether Ministry of Health, I think in line with Zambia National Public Health Institute, to be able to see whether this can be mainstreamed as something that can run, or if they have modifications to it, we can see how we can modify it with them to be able to see how it can run as a CPD for health workers. So we are still working on it, and we think we welcome any collaboration that we can have on this.
Can I just ask a very quick question linked to that? Is this separate to the CPA AMR modules?
Yes, so this our module was developed within the project. I think that was before the CPA one came up. And I think it was more contextual because what happened was we had to use a local needs assessment that perhaps was done internally within the project. And then we got content experts within the project to be able to help us write the modules in collaboration with the partners in the UK. So we came up with a structured document. So this document is one which we kind of have now, and we're trying to use to scale up to become a CPD for Zambia.
So
But
just one more question. It's for all healthcare workers rather than pharmacists, is that right?
Yes, exactly. It's a general program which can be scaled up to all cadres.
Yeah, so in addition to AMS, I think Otrida is online. Eunice, Otrida is on the line from ZNPHI.
Yes, please.
So currently the module, I think we handed it over to ZNPHI, that is Ministry of Health, to have a look at it and maybe finalize later on so that it can be rolled out.
Yeah, Otrida has been, his hand has been up, but I think we had lost that for a bit. Otrida, could you go ahead, please, with your question?
Thank you so much, Chair. I had been putting up my hands and eventually I got kicked out of the meeting, but thank you for the opportunity. Hello, everyone. Thank you, David, for the presentation. It's It's encouraging to see how much work has been done and went into this project. I have a number of observations to make and some comments and no questions necessarily. When the project was just starting at inception, we were made aware and there was representation. Maybe just allow me to give a brief background to the governance structure for AMR activities in the country. So we have a national steering committee chaired by the Permanent Secretary, Ministry of Health, and co-chaired by the Permanent Secretary, Fisheries and Livestock. And this is the committee that oversees all AMR activities in the country and basically implementation of the National Action Plan. Then we have more of a technical committee, which is the Antimicrobial Resistance Coordinating Committee that coordinates implementation of all AMR related activities in the country. Partner supported included. And so this is the avenue that we've encouraged all the projects to come through when there's an opportunity for funding and to implement any AMR related activities. Apologies for those that may not know. So I'm currently serving as a national focal point and coordinator for AMR in the country. So I'm overseeing and coordinating implementation of AMR activities in the country. Below the coordinating committee, we have different technical working groups: optimization of antimicrobial use, surveillance and research and development, surveillance, IPC, awareness raising, as per our National Action Plan. So when this project was just starting, I think I received an email, and at that particular time, I wasn't in town, but members of the coordinating committee were in attendance, and we did encourage the people who were leading the committee to get in touch. I was hearing about the challenges in navigating the system. When we received communication that you wanted to support selected facilities to be able to make their own hand rub and improve IPC, I think the response was very clear that you needed to ensure that you coordinate this and work with a coordinating committee to avoid duplication of efforts. A lot of activities have been done, and I was looking when you were making the presentation, some of those activities, because the main partner that is supporting stewardship activities in the country is REACT Africa. We have selected facilities, including UTH and Ndola Livingstone, and some of the facilities were targets under this particular project. So I saw a lot of duplication of effort, and I think maybe in future we need to align better and communicate better so that as we are implementing, we are ensuring maximum utilization of our resources. So what happens is that a letter is drafted by either the chairperson of the steering committee or the chairperson of the coordinating committee, who's Director General, ZMPHI. And when you go to any facility and carry that letter, anyone recognizes it. So probably the reason why there were all these challenges, it's because the avenue you were using is not according to the governance structure set in the country. So thank you very much for the support and the work. I just thought that I needed to add the voice of the AMRCC. There's a way we're coordinating, and there's the way we are approaching. Another thing is that a decision has been made that even if support comes in form of a project, when we implement, we are implementing as part of implementing the National Action Plan on AMR. We align with what's already existing. That is important for sustainability beyond the support, because if we implement in project mode, what happens is that once the support is done or withdrawn, all those activities come to a standstill, and that is what we are trying to discourage. I acknowledge the document, the stewardship training package that was talked about was handed over to the AMRCC when we were invited to a validation meeting. Unfortunately, we couldn't validate a document we were seeing for the first time. And so we requested that we needed time to go through it, and members of the AMRCC are going through it, and we totally support the initiative. And the idea, like said, is that eventually this is rolled out as part of CPD for all healthcare workers. Thank you very much for the opportunity to add my voice. Thank you.
Thank you very much, Otrida. Thank you for the insight. And I think we are, as a Zambia team, through our interaction with you, we have learned one or two things. And I think going forward, we know the right path now. I remember when we were doing the Kitwe Livingstone, I think the letter came direct from ZMPHI, and I think it was very clear. We're grateful for your support, and we always remain in touch.
Thank you, everyone. There's still some people with burning hands. Well, I must say thank you so much. This has been a very rich discussion, and thank you to David for the presentation and all the team for the contribution and for the responses to the answers. I think we've reached the end of this session. I'm now going to pass on to Richard. Please do stay and listen to the Tanzanian presentation. There could be, I'm sure there will be a lot of lessons to learn from there as well. So Richard, I'm passing over to you now.
Thank you, Eunice. I just want to check whether with the notes that Diane was taking, whether we just want to agree on those before moving on to Tanzania. And Diane, I don't know if you wanted to come in.
Yeah, sorry, one moment, I'll share my screen again, just so we can agree on for the feedback. So hopefully you can see the Google Doc.
Yeah.
I think we agree that is Aubrey feeding back?
Yes, yes, I'm able
so
to
yeah,
see.
it's what we, because there's only 3 minutes, it'll be 1 point from each of these. So I don't know which key achievements you wanted to focus on, and then what one biggest challenge. We just need to highlight them so that you have it easy to hand to use. Or maybe perhaps we focus on the recommendations for the Ministry of Health.
Yeah, I think we can focus on more of the recommendations. I think those will carry more weight. I don't know.
Okay, so are these two? I got one from Anya in the chat and one from when you were speaking. Is there anything else that anyone else in the room wanted to add, or any other colleagues in the room wanted to share? I think
yeah, I think I got those two as well. So I'm not sure if there are any other, then we can add. But if the two are standing, then we can have them stand.
Okay, all right. Thank you very much in that case.
Thank you.
Thank you both. Thank you. Okay, well, let's move on to Tanzania now. So we have, just under an hour before we go back to plenary. Ideally, the session would have been run by our country director in THETS, but in Tanzania, but we're actually between appointments. Godwin left at the end of last year. So I'm a very poor substitute to facilitate this, so bear with me. As when Godwin did leave, he did teach me a few things. So habari za mchana, karibu sana wote kwenye mkutano huu, jina langu ni Richard. So hopefully I said my name is Richard at the end there, Head of Grants Management at THETS, and I'm really delighted to be running this session with you. We should be joined by Emiliana Francis, the pharmacist at the ministry, who was due to give a talk at the start, but I don't see her name on the list of participants. If you are here, please do speak up now. And I have messaged separately, and I didn't receive a response, so it may be a similar thing as we had with Zambia. So I think let's move straight into the presentation and hope that Emiliana can join a bit later. So yes, we're due to hear from Northumbria and Kilimanjaro Christian Medical Centre to present achievements, challenges, and how they contributed to the AMR National Action Plan. So I think we're all ready. I will hand over to you guys. Is it Scott speaking up first?
Yes, please, yeah.
Thanks, Scott. Do go ahead.
Okay. So, oh, brilliant. So one thing I wanted to note really was Northumbria and Kilimanjaro Christian Medical Centre have had an existing partnership now for it's over 20 years. So when we saw the opportunity for this grant become available from TEP, we got very excited about what we could achieve, because we'd already had this partnership and all these relationships already there. So that really put us in a really good position, I think, for what we could actually do with this funding. The other thing which was really exciting was the fact that it talked about specifically having pharmacists within this project, and again, that really sort of looked like a fantastic opportunity for us as a profession to really get involved in this. And I think we have done. I think we've really sort of shown everyone what pharmacy can do. So so I think on the call here we've got Dr. Eva Moreau, Dr. Florida Moreau, and Dr. Sarah Urasa also on the call. So we'll just talk around the slides that we have here. But if there's anything that you guys want to also talk a bit more detail into, please feel free. And Joseph's here as well, Joseph Brayson from Northumbria, and he'll talk about some of the other aspects that, of the project that we would do. Okay, so we've just put down three of the achievements that we've done. I think just to give a little bit of background to how we actually planned the project from the beginning was because we've done a lot of this before, we agreed that it would begin with having a 4-week observership from the KCMC lead team over in the UK, and that would be the first thing that we would organise. And I know it was a long time, 4 weeks is a long time to be away from home, but it was such a great opportunity to absorb everything, related to, how the pharmacists are working in the UK, and also how antimicrobial stewardship and IPC worked in the UK as well. And then at the same time, think about what sort of things there would translate well into Tanzania and into KCMC specifically. So that was a big part of the project, and I know it was a long time, but actually it worked quite well. And immediately following that, I think there was only a 7-day gap when we actually joined the team over at KCMC to then do 2 weeks to support with the UK team to support the project work. And again, because we'd done 4 weeks leading up to that, everything was sort of ready to go, and the momentum was there. And we talk a little bit about some of the things that we had to sort of overcome, and I think one of them was having such a fantastic plan in the 2 weeks when the UK team were there, made it so much sort of everything that we could get out of it really was, we couldn't really get any more out of it than we possibly could. It was such a fantastic absorbing opportunity for both the UK and the KCMC team. So one of the first things I put there, well, this was the main part, or one of the main parts of the project that we had to achieve was around sort of the AMS and IPC awareness. And that was for, the main focus initially was sort of for the those staff that are working in the KCMC, and that included the doctors, the nurses, the pharmacists, and the interns, the students. But then we also wanted to include the community aspects as well, so the community workers, and then following on from that, probably later on, linked with World Antibiotic Awareness Week, how we were getting the messages out to the public and to the schools at the same time. So we sort of didn't really hold back with this. We just sort of said, right, this is an important message, and we're just going to really go for it and try to capture as many people in different ways in order to get the message out there. So then, I know it's difficult to see, but you can see on the first graph there, overall, we managed to get the message out to over 1,000 people. And that was different ways that we did that. So we did some formal lectures, we did some classroom activities, some case-based discussions, mainly did with the pharmacy team. We did posters, we did role play activities. So lots of different ways that we could actually get them, different ways of getting the message across. Interestingly, so when we had we had to really take into account was if we're presenting a message, of people getting that message across. So we made sure that we also included, certainly in the later part, where the public awareness and the schools, we needed to make sure that we had Swahili translators, and we looked at the material that we were using, so the handouts and the posters, and made sure they were translated at the same time. So we didn't want that to become a barrier for getting messages across to the different individuals. So so that worked really well. So yeah, over 1,000 people got this education, and we also did some other little bits where we tried to measure the did they feel that they understood the message, just sort of very basic ones, and it was evident that the message was getting across. So that was excellent. It worked really, really well. There was some other things with the IPC elements of the education where we had some practical exercises. So we had one of the team actually that from the UK that we took over to KCMC was one of our infection control nurses, Ruth. So she brought her cream and everything, and we did lots of hand rubbing activities and used ultraviolet light, and just to sort of, again, a very easy way of showing how to effectively wash your hands. Again, something that's really benefit probably later on down the line with the activities with COVID. So that worked really well at the same time. And again, it wasn't just sort of the other part of this, I guess, which really sort of developed quite naturally was, but amazingly was, so Eva, who was part of the educational aspects of this project, we were then getting into discussions with Northumbria University, who's just near, Newcastle University, who's just near here, where the hospital site is here at Northumbria. And we started discussing, could we create a joint sort of AMS module that would translate well into KCMC, but also for our UK partners. Because actually, when we looked at what was on the syllabus, it didn't actually include AMS at the same time. So, well, but let's take this as an opportunity to create something, but again, would work in both areas. So, so that worked fantastically as well. And again, great way of actually sort of taking an opportunity where there is a gap in provision of AMS awareness and creating something that we thought would work across both UK and Tanzania. So so I've talked a little bit there. I don't know, Joe, did you want to talk a little bit about the next bits, the surveillance?
Hiya, I'm Joe. I'm one of the other pharmacists over at Northumbria that was involved with the partnership. I'm going to spend a little bit of time talking about the sort of surveillance element of this. And as Scott said, we've tried to divide all the aspects of the project into three broad categories here. But I think what I'll try and highlight with the next part is there's so many elements feeding into these three categories, but there's just so much you can't fit it on a slide, unfortunately. So one of the main objectives we set out with initially and during the first trip to KCMC was to try and collect some robust data and gather some surveillance on antimicrobial usage, antimicrobial resistance as well, because as the speakers this morning have sort of alluded to, having that robust data is really, really important for targeting our interventions and for making a difference towards AMS going forwards. So we ran the PPS over the first trip in June and then repeated it in November. We surveyed approximately 1,000 patients in total over the two trips. So we have a relatively large cohort of inpatients which we can look at their antimicrobial usage of. Whilst we were there in the first trip, we had a huge effort from the KCM team of data entry so that we could get the data on the system and start the analysis whilst we were there and start looking at this data and looking at how does KCMC compare to other similar countries within Africa. So looking at Uganda, Zambia as well as some of the comparators, and then looking at where the hospital performed really, really well and where the hospital could try and target some of their improvements as well. So things like documentation were really good within KCMC. I think we took things back to Northumbria to look at our own documentation as to indications and course lengths and things like that, because that's something which we often struggle with here. But then we sort of noticed some trends around broad spectrum antimicrobial usage and a tendency to prescribe them over some of the more targeted therapies. And we used that data from the first trip to target some of the interventions going forward. So we sort of thought, how can we try to reduce this? How can we try to address this problem? And actually, when we repeated the PPS in November, we did see a reduction in the usage of those, some of those categories of antibiotics. Now that's just one repeat of the PPS, so I don't think we can put too much emphasis on that reduction, but it's reassuring to think, okay, well, these things aren't going up, or that we have seen some reduction, and hopefully if we do get the opportunity to repeat some of this work, we can see that reduction continuing. And I think it's useful to highlight that red arrow going between those two graphs actually represents a huge amount of work from the team at KCMC with the support of the teams at Northumbria as well. Loads of different elements and interventions going into that to help sort of start to produce that culture change and that shift in prescribing habits and usage of antimicrobials. I'll hand back over to Scott to talk about the next point on that page, which is one of the sort of key interventions or things that occurred as a result of the data collection.
Okay, so yeah, so something that we didn't actually put as a goal for this project, but something that happened naturally, possibly from some of the team coming to work into the UK and us coming.
Sorry, could I ask everyone to mute if you're not presenting, please?
Sorry.
Thank you.
So yeah, so something that happened naturally, which was really exciting, and probably one of the biggest interventions that really we could have possibly hoped for, but we didn't put in the plan, was the starting of a development of the pharmacy team, the pharmacists within KCMC, looking at the opportunity for providing clinical pharmacy service under the medical ward rounds. So this was something that happened quite naturally. So and something that was asked from the KCMC pharmacy team while we were there. So we did so Joe, and I know Emily was part of this, did some sessions around, some basics around, how we do, what the main sort of areas are of clinical pharmacy that we provide here at Northumbria, and how maybe that might relate to in a similar way to the hospital at KCMC. So that was very much in its infancy, but it was so fantastic to see, you know, just how much the team over at KCMC really were interested in this and wanted to see how it could work for them. And if you think interventional wise, we're talking here about antimicrobials, but if you think about clinical pharmacy generally, it isn't just end with antimicrobials. I mean, you have lots of other patient safety work that pharmacists and technicians can provide on the ward-based services. And this was such an amazing thing to see happen, that actually it was, well, this is potentially could be the biggest intervention we could have ever really dreamt of as part of this project. So I know that at the same time, this is quite a big challenge, because you know, there are specific roles that need to be done within the hospital, in KCMC, and in all the other hospitals across Africa and everywhere else. But it was great to see that that awareness of something that could be created later in the future. And hopefully this project was the beginning sort of steps of that becoming a bigger thing. So I wanted to put that as an achievement, even though it was very much in its infancy. But I really think that when you think across the pharmacy profession and how it's developed over in the UK, this is a similar sort of journey that the pharmacy team over in Tanzania, I'm sure, and the other hospitals in Africa are noticing as well. And obviously it was discussed with Zambia project at the same time. So again, a fantastic achievement from, even though we were aiming initially in one area, which was antimicrobials, but you can then see how this could grow and grow and grow. So I put that as an achievement, but and okay, it's probably not particularly easy to measure at the minute, but I just thought I would put it on because I thought it was fantastic. Okay. You might have control, I guess. Can you push this out? Oh, great, okay. Challenges, okay. So yeah, obviously COVID was a big challenge. The main thing that's affected us with, so one of the elements of the project that we really wanted to include was the community pharmacy aspects of this project, because we were sort of talking here, certainly at the beginning phase, we were sort of saying, okay, there's all these things that we could do and affect within the hospital environment, and okay, education wise, some more for the public and community services, but what were we sort of ignoring the elephant in the room, which was, where's the vast amount of antimicrobials being used here? And it was in the community, and it was, so we wanted to do some work around focusing on the community pharmacy aspects of supply of antimicrobials, and some of the behaviors and understanding of the public going to the community pharmacies to obtain antimicrobials at the same time. But I think this was the final part of the project we wanted to do. So it's still there. It's still something that's really important, I think, and something we still want to do. So, but obviously COVID's made that really difficult for us to work on at this time. The other challenge was, we were very much aware, certainly from the UK side, that we were asking a lot. Certainly when we were doing the PPS, we were asking a lot of the pharmacy staff at KCMC as well. We were sort of, they obviously have a job to do that for the natural running of that hospital at the same time. And we were pulling a lot of those guys to do some education sessions to educate them on how to collect data from the wards, to then actually collect that data. So this was a big chunk of time for them. I hope, but actually it all happened, and actually it was amazing just how generous the team were providing that. It was really fantastic, but I really wanted to make those guys aware that I felt very guilty about doing that, because I could see that they were really working hard just in their day-to-day job, and I was asking them to do another thing. So so I really appreciate the effort that they made on the basis that it was tough at the same time. So thank you to all of those guys for doing that. And finally, I think I've already talked about this. This was sort of how do you sort of get as much as you can out of those 2 weeks that you were there? How do you, for the UK team that were at Tanzania, at KCMC, how do you sort of support as much as you possibly can in 2 weeks for when you then go home and have to, allow that to continue and develop naturally? So that this was really actually worked out very, very well, because as soon as we arrived in the UK, so Eva and Peter had actually created a timetable, exactly what we were doing on every day, and that worked fantastically. I don't think we could have actually done any more than we had done in the time that we had planned. So thank you to Eva and Peter for creating that, because I think that was a great way of making sure that we were on track and we got everything out of this project that we possibly could. Do you want to talk about the next part?
So this next slide is really trying to focus on how this feeds into the bigger picture, because obviously that's ultimately what we're trying to do here. We're one small part of both the National Action Plan, the Global Action Plan, and the work that all these partnerships are doing that we're hearing about today. So we tried to sort of take a bit of a step back and think, well, how does this feed into that bigger picture? So as part of the work we were doing, some of those interventions I talked about before we implemented or provided access to sort of guidelines. So within Tanzania, there is the national guidelines, which includes antimicrobial guidance for the treatment of infections. And we basically, together with CwPAMS, developed the micro guide app, a platform through which those guidelines became much, much more accessible. And in doing so, we're empowering clinicians to utilize them to make their decisions at the point of care, so that they can make sure they're using them as appropriately as is possible within their resource. We were really fortunate within our partnership that we had Dr. Ava Muro, who was appointed to the National Antimicrobial Steering Group. Really fortunate to have Dr. Muro within the team, so that she could provide a voice and speak about some of the work that we were doing within our partnership at a higher level, and really make that contribution at a higher national level. Within the training that we provided that Scott talked about, we were able to increase awareness to antimicrobial stewardship and to resistance. And then taking that a step further with this co-developed undergraduate module, we were able to sort of embed that within early years training and ensure a longevity of that awareness, and produce future generations of pharmacists and pharmacy technicians who will have a greater awareness of it coming through from their training. So again, just really embedding that and ensuring longevity there. And then by carrying out the surveillance in establishing tools to collect that data, we've essentially produced a baseline that we can look at going forward. So when we do repeat the PPS modules, or when we are able to roll out that model of data collection to other hospitals within Tanzania and wider, where we have that comparison and we can look back and say, how are we changing from that baseline, which is really important, both from a monitoring point of view, but also from a general AMS surveillance point of view. And then by continuing our work with increasing public awareness is really important as well. So it's not just about training clinicians, pharmacists, doctors, nurses, those people. It's about increasing the public awareness as well. So starting from school-age children around IPC, hand washing, hand hygiene, that sort of thing. We ran sessions with huge cohorts of boda taxi drivers, because they talk to all their customers as they drive them around, and that we thought it would be a really great way to get the message out there in the communities and get them talking about when antibiotics aren't appropriate for infections, hand hygiene as well, and the importance of good IPC practice in the community as well as in the healthcare settings. So those were just some of the ways that we think our work has contributed, and hopefully will continue to contribute to the National Action Plan within Tanzania, when we can sort of resume some of the activities that we had planned. And I think is there one more slide? Excellent. And then plans for the future. So I think everyone involved, myself, Scott, and hopefully our partners over in KCMC want this to continue. We don't want this to stop, and we weren't ready for it to stop when it was forced to by the current situation. So as soon as we can, we want to continue the momentum and get it off the ground again, continuing our AMS work, but also looking at other areas. So we mentioned the sort of the infancy of the development of the clinical pharmacy service within KCMC. We're really keen to expand on that, both for antimicrobial stewardship work, but also looking at other clinical areas. Where can we expand? Where can we use this to really drive things forwards within KCMC and continue the work that we started? Scott, do you have anything to add to that?
No, I think we've talked enough. I don't know if either of Florida or Sarah want to mention anything.
Hello, everyone. Peter is here as well, Scott. Peter is signed in as KCMC.
Brilliant.
Yes.
Oh, brilliant. Hi, Peter.
Hi, Peter. Sorry, we weren't ignoring you.
Hi, good afternoon.
Good afternoon,
Hello.
Peter. Hi there, Sarah. Is there anything you wanted to add to the presentation?
Thank you, Mr. Scott and Joe, for the presentation. I think almost you exhausted everything, and just to add up, I want to remind the team that even our EMR committee in the hospital was just started by our director just 1 year ahead, and through the collaboration, they came on and strengthened the committee, and now it is somehow strong. Even yesterday we had a meeting to discuss some issues with the team from the ministry. So that is a big achievement. And through the committee, we have a good plan to strengthen our formulary through increasing some imports to the formulary in the area of antimicrobials. That will help us to improve our stewardship as well. That is all. Thank you.
Thank you, Peter. Yeah, that's absolutely great. Thank you so much to Joe and Scott for the presentation. I'm just blown away by what you and the Zambia team beforehand have achieved. I think when we set out on this grants program, you know, maybe in our slightly wildest dreams we could have hoped for something like this, but the amount you have achieved with such a limited budget in such a turbulent time is incredible. And I really hope that you know, this is acknowledged and seen across the UK and in sub-Saharan Africa. I did just want to say a couple of things. So I was taking a few notes like we've done for the Zambia group, and I wondered whether we could have a volunteer to speak through the headline points for 3 minutes through the Google Doc, which Diane has just shared her screen now. I've also linked to it. Could we get a volunteer from the Tanzania partnership to just talk through those main headings? Scott or Joe, I wonder if you could, it's basically just repeating a presentation, but in a much more limited.
Yeah, I'd be more than happy to.
Is that okay? Great. Okay. Well, Vicky will invite you in the next session to speak in that case. Thank you, Joe. And before we go to questions, and discussion, do have a think about what you'd like to ask. I think we've been joined by Emiliana Francis from the Ministry of Health. Emiliana, can you hear us?
Hello.
Hi, Emiliana. How are you?
Hi, everyone.
It's great to have you here. I think you shared slides previously, didn't you? So we could go to your presentation if that's helpful.
Okay.
Audrey, if you could get through.
Sorry, can I present now?
Yes, we're just getting your slide up now. Hold on 1 second. Yes, here we go, Emiliana. Yes, so over to you. Thank you.
Okay. Good afternoon, everyone. I'm Emiliana Francis, pharmacist from Ministry of Health, Tanzania. We just take you through the AMS stewardship in Tanzania, especially at the ministry level. What have we done as a ministry on the issue regarding antimicrobial resistance? We have this AMS, we have kept it into 6 core pillars. That's our inputs, the activities that has been done, the outputs, outcomes, the objective achieved, and goals. The inputs that we have in implementation, we have funds for implementation. We have also technical support from fellows who are who are expert in AMS, and also we have in-house that the technical supports, like they trained personnel from the ministry who are capable of taking this AMS to further steps. Also, we have been developed the guidelines, the policy guideline for combating AMR. We have strategies, and we have a national action plan for combating AMR. Also, we have been developed the training materials, and the supervision tools and the mentorship. The activities that we have been done so far, we have done the antibiotic selection, that the aware selection. We have managed to develop our own aware list that we use we use a WHO model in developing, and we have managed to integrate that list into standard treatment guidelines. And our future plan is to disseminate that and to help the facilities to
Sorry, Emiliana, I think we're losing you there. I assume it's not just me.
Not just you.
Okay.
Is from that to
sorry, Emiliana, we lost
can you hear
there
me
for a while, but we
can
hear
you
you now.
can you
Yeah,
hear me?
we can hear you now. I think we lost the last 30 seconds or so, if you wouldn't mind.
Okay.
Yeah.
We have managed to conduct a PPSC survey that help us to evaluate the antimicrobial use, to have just a snapshot of evaluating the antimicrobial use, especially into our regional referral hospitals and some of the zonal referral hospitals. And we have just used that result to set the interventions that could help us to monitor the antimicrobial use into our hospitals. Also, we are continuing with the activity of mentorship, supervisions, and also we are going to launch an eco session, which is a online learning session that facilities will have the We'll have the time to represent some cases, antimicrobial cases from their working areas. And this session will help us to engage more facilities in the AMS program. Also, the outputs from the activities that we have done, we have health workers who have been trained. The awareness of AMR for health facilities has been increased through activation of health hospital therapeutic committees. And also we are monitoring a continuous improvement, continuous quality improvement in terms of the antimicrobial stewardship. And also we have already a guideline, which is a standard guideline, which is a standard treatment guideline, which we are going to use it as a tool for monitoring antimicrobial use, which this guideline, the aware list, it is included in it. The outcome of these activities is to reduce the risk of AMR, improve service at the facilities, also improve the patient care in terms of reduction in nosocomial infection and the mortality. We are doing all this in order to promote and protect the public health. I may just share just few challenges that we are facing in implementing the AMS activities at the ministerial level. The major challenge, other are just minor, but the major challenges is in availability of funds for implementing the AMS to our health facilities. We can see up to now, for the support of the ministry and the other partners, we have just managed to implement the AMS to just only 10 facilities, and we have many facilities. You can see that. So the fund will make us escalate this AMS implementation up to from the zone of facilities up to the dispensary level. Thank you for listening.
Thank you so much, Emiliana. That was a really helpful and comprehensive run through of Tanzania's strategy with regards to AMS, and really helpful to see some of the challenges as well that you're facing. And that's really put into context the work that CwPAMS can do. Could I just ask everyone to mute themselves if they aren't speaking, please? Thank you. So yeah, thank you so much. So we'll open the floor to questions now, if that's all right, either for Emiliana or for the partnership. I noted that Sarah had her hand up, if you'd like to come in, Sarah. Actually, sorry, one thing first. No, don't worry, let's carry on. Question from Sarah, thank you.
Hi there. I thought that was a brilliant presentation about Tanzania. I was so impressed with everything that you're doing, because I've been slightly involved with the work in Zambia. I just wondered, you talked about this AMS module, and I wondered whether that was just for pharmacists and pharmacy technicians, or whether you'd thought about rolling it out to other healthcare professionals, such as doctors and nurses. Or is there already AMS training for them in place?
No, there isn't.
Yeah,
No,
this is what we noted in Zambia.
There isn't in the UK neither, so that was interesting to see for the doctors and the dentists and the other guys in the hospital that, in the university, that they weren't talking about that at undergraduate level, even though it's such a public risk, you know. So yeah, so I think that was a great chance, because you know, there's obviously a need for it. And we're like, well, great, well, let's just try to provide something, and you know, let's just sort of put something out there. We'll collaborate, you know, work together, create something, and then just see if it's fit for purpose. If not, it's okay. At least we've had a go, and maybe it's the next module that then gets created will be even better. But at least we're beginning the journey, as it were, of getting the awareness in there at undergraduate levels.
Fabulous. But it's quite hard for pharmacists, I think, to argue the point with doctors who are prescribing if the doctors don't have any background on what is actually, what is relevant, what's needed. I just, in terms of empowering pharmacists to help make decisions, we talk about clinical pharmacy. That was just a thought anyway, but I think it's brilliant.
Thank you, Sarah. Diane, did you want to come in on that point?
Yeah, just wanted to clarify, Scott, what the module you're talking about is for undergraduates rather than qualified professionals, or is it for qualified professionals?
I mean, I think the one that Eva and it was Adam from the university were creating was for undergraduates.
Thank you.
But I don't see why that wouldn't be useful for postgraduates at the same time. It's just a case of sort of creating something and then tailoring it to your audience, I guess. So it could be a very intense module, or it could be just the sort of beginnings of, you know, awareness modules. So, but at least it would all be in there, and you know, I think we just really were excited to get started with it, just to see if it could, you know, become something bigger. Really, to be honest, that module was also then beginning discussions around the memorandum of understanding that we already had with Newcastle University and KCMC, and then thinking about, is there something that obviously the medics have been doing for years, where we have undergraduates going overseas to do some of their elective projects, and whether that could happen with undergraduates in the pharmacy school. So we checked with the memorandum, and actually there was no reason why that couldn't happen. So again, that got very exciting, but then COVID came, and it just sort of, we had to sort of put it a little bit on hold. But that was always there in my mind, that why is that different? Why wouldn't we gain the same sort of, learning and understanding and appreciation, both for the KCMC guys and the Tanzania undergraduates coming to the UK and vice versa. So, so I guess that was maybe the final amazing thing that could have happened, and where we did begin, I guess, having those discussions around the memorandum, and actually it is there as a possibility into the future. Sorry, I totally went off subject there a little bit.
Thank you.
Thanks, Scott. I see Karim has got your hand up. If you're able to unmute and introduce yourself.
Thank you. My name is Karim Wanga from Kenya. I have one question and a few comments. My question is, how did you deal with the issue of sustainability of this work, especially integration in the routine work plans at healthcare facility level, the hospitals you're working in, especially building capacity for these pharmacists to be able to carry out point prevalence surveys, at the end of even when the project comes to an end. In terms of comments, I took note of the approach on using border taxi drivers in creating awareness. I think that's something we can learn as Kenya, because we have quite a big number of the riders, and they can help us to reach out to a big population. The other comment is the work that was being done at Kilimanjaro. I think it's also important to link surveillance on use with the laboratory work, microbiology, especially at microbial susceptibility testing data, so that these can also help in development of antibiograms for the hospitals. And then lastly, a comment on the presentation by Amy. She mentioned that there was integration of the AWARE classification or categorization into the standard treatment guidelines. I also wonder whether the same was integrated in the national essential medicine list. So that maybe that's a question that Amy could also address. Thank you, and over.
Okay. Hi, thanks, Kareem. Thanks for the comments and for the questions. I'll maybe work backwards. So from working with the microbiology labs, we did work really closely with the labs at KCMC, and we allocated some funding to look to increase capacity in the lab for testing and for processing samples, because we absolutely agree with what you said. You can't really do lots of work and expect encourage people to send cultures and sensitivities, for example, if we're not also ensuring that the lab has the capacity to deal with an increased demand for cultures and sensitivities. So we work very, very closely with the micro labs, and absolutely that's a really important thing to consider. I don't know if Peter's maybe better positioned to comment on the sort of resource within the department at KCMC, but I certainly know it was challenging. The staff within the pharmacy department gave up a lot of their time to facilitate particularly the PPS, because as I'm sure lots of people are aware, it is quite a labor intensive model of data collection. And I don't know if Peter has any comments on that.
Thank you, Joe, and thank you, Mr. Karim. So from the side of UK, if you remember, last time we used a few staff and the intern pharmacists, and what we did, you trained all of us, and everybody was aware about the procedures and taking this global PPS surveillance. So even the last batch of our intern pharmacists went out. We have a new batch, but the few staff who remained, we have enough capacity, and we used to train, and it is one of the agenda or topic when we orient our newcomers. So even in time of doing another PPS, perhaps this year we are planning to do it again in November. So our staff we have will train the intern batches, and then we'll move on. So even if after this project ends, we will sustain to do the same things as we did before during the project. Thank you.
Thank you, Peter. Did that answer your all your questions, Kareem? Was there anything else I missed?
Yes, you did, except for on the comment for incorporation of the AWARE classification into the National Essential Medicine List.
Fine. I don't know. Is it Emily? Sorry.
Emiliana.
Emiliana. Sorry. Are you still on the line?
I can help answering that question.
Oh, thanks, Eva. Yeah.
Hello? I can help in answering that question. So the AWARE list of antibiotics have been incorporated into the standard treatment guideline of Tanzania, which would come out this month. Actually, it was signed last year during the PSU meeting of our civil society in Tanzania. So it's incorporated in the standard treatment guideline.
I'm not sure if Karim caught all of that. You're slightly breaking up there, Eva.
Did you hear me?
Would you mind just repeating the last 20 seconds or so? I think you broke up just towards the end.
Yeah, the AWARE list of antibiotics has been incorporated in the standard treatment guidelines of Tanzania. We have a new version that is going to be out soon. It has already been signed by the Minister of Health.
Okay, thank you, Emma. And thanks, Karim, for your question. That's really helpful and interesting. And yeah, of course, do reach out to us at FET and CPA and other partnerships if you have more questions around the CwPAMS and the work we're doing. I think every conference could benefit from having incidental jazz piano music in the background. So thank you. Diane, you have your hand up.
Yeah, I just wanted to check in terms of recommendations to the Ministry of Health, if colleagues from Tanzania had any specific recommendations they wanted to highlight.
Well, one way of looking at this perhaps is, what's quite interesting is it's obviously great that Eva's been on is it the AMS National Strategy, I can't remember what it's called now, the committee, yeah. You know, either what are plans for the future, kind of, yeah, for recommending for government action, but also kind of what added advantage has that benefited your partnership as opposed to potentially other partnerships. Now maybe that's not something you guys can answer, but maybe other partnerships can speak up about that. But I'd be interested to find out what the differences there are, what the added value is. I don't know whether Eva is best placed to take that.
Well, I'm not quite sure if I'll be able to answer that question, but my understanding is that currently they have the National Action Plan for Tanzania, and they're also making activities for how are we going to control antimicrobial use and antimicrobial stewardship. So they already have a policy that is already out, and now they are trying to make a framework whereby they'll come up with activities on how are they going to measure the outcomes that they are anticipating in 2022.
It sounds like you don't have any direct recommendations, and I guess maybe that's partly because you're already in kind of very constant talks with them on a consistent basis.
Yeah, I see Siana is signed in. I'm not sure if she's still in. She'll have the actual answers for those questions. But I understand now they are making a framework for how are they going to run the activities.
Great, thank you, Dr. Eva. Okay, we have a few minutes left. Are there any final questions or comments?
I think the only thing I would say is the thing probably we would like recognition about the projects, the grant, I guess, is really to say just what you can accomplish if you do include pharmacy profession within those grants. Sometimes I know previously a lot of them very much built around research and medical elements to it, but I think this opportunity that we've had, the fact that it was so specific about having an antimicrobial pharmacy activity within it, and then you can actually see just what you can achieve interventional wise if you have pharmacists and technicians included within that. So I think that would be something we would really want to take forward. We haven't even been on the other groups who will be talking about all of the things that they've achieved at the same time. So it just shows you what you can do with them. It doesn't have to be huge bits of money, but if you've got the right people in that team, the difference you can make can be quite big and lead to even bigger things. So I think that's the thing that I've really learned as part of this.
Would you like us to include that as a recommendation to Ministry of Health?
Absolutely. Definitely include pharmacists in all your grants.
Richard has typed it out already, I think. So.
Bro.
Yeah, thank you, Scott. Any other thoughts? More questions? if not, then I think we'll leave it there for now. And it just leaves me to say thank you so much to our speakers, so Scott and Joe, for putting the presentation together and talking through all your many achievements. I know it must have been pretty hard to get that down into 3 slides, but it's absolutely phenomenal what you guys have achieved. It really is. And we're so proud here at Set and CPA of everything you've done, and we really wish we can continue supporting you in the future. So thank you all, and thank you to Emiliana for your talk as well. That was really helpful to set the context in Tanzania. We have 7-8 minutes until the next session, so I would suggest taking a quick break before we return to the main room. Now at 1:15, there should be a pop-up on this screen that will enable you to go back to the main room. So wait to see that and then head back. And I think, Joe, we had you down for the presenting the notes, so thank you. Just make sure you clicked on that Google link, so you got it. Great. Okay, thanks so much everyone, really appreciate it, and yeah, see you in a few minutes time. Bye.
I think you're welcome to stay in here, and then it will take you automatically back into the main room, or you can leave room and go into the main room.